Pneumocystis pneumonia. The first point that we need to understand here is that this infection is the most common AIDS-defining infection. And AIDS-defining infections, there are many of these infections. They mean simply that these infections occur when CD4 count is less than 200. And for your exam, you should know that PCP pneumonia or pneumocystis pneumonia is the most common AIDS-defining infection. Other types of AIDS-defining infections include esophageal candidiasis, and take care, it's not oral candidiasis, it's esophageal candidiasis. And also we have Kaposi sarcoma, and also we have progressive multifocal leukoencephalopathy, and the last one is cerebral toxoplasmosis. All these are AIDS-defining infections. When you find any of them, you should suspect AIDS. So if we want to know first what's the causative agent of this type of pneumonia, the causative agent is called Pneumocystis jirovecii, and this is the new name. The old name was called Pneumocystis carinii, and this is why it was called PCP pneumonia, Pneumocystis carinii pneumonia. But nowadays, this term Pneumocystis carinii is replaced by Pneumocystis jirovecii. And what's important also is that this organism, it was previously classified as a protozoal infection, but no longer it's considered a protozoal infection. It's considered a fungal infection, a special type of fungal infection. So Pneumocystis pneumonia is caused by Pneumocystis jirovecii, which is a special type of fungus infection. So this type of infection is transmitted by airborne infection or inhalation. And the most important risk factor for it is immune suppression, such as HIV. And this type of infection, it rarely or it cannot cause significant pneumonia in normal people, only in people with HIV. So clinical picture of this type of infection, usually the patient will present with symptoms and signs of pneumonia. But take care, because these people, they are usually immune suppressed, meaning that they may not show significant symptoms of pneumonia, and the course is usually gradual onset. So you can expect low-grade fever, dyspnea, and non-productive cough. This point is important for your exam. The cough of PCP pneumonia is usually dry cough. And on auscultation, you can find crackles or rhonchi. This is normal for any pneumonia. And what's important is that saturation is usually less than 90% at rest and worsens with exertion. This point is very important. It will give you an exam scenario about a case in which the saturation drops more when he walks, for example. At this point, you should think of pneumocystis pneumonia. So if we come to the diagnosis, the best initial is chest X-ray. And chest X-ray, it will show interstitial infiltrate extending from the perihilar region. Let's have a look on the X-ray. You see it's called bat wing appearance, or another name is called butterfly appearance, meaning it starts here from the hilum and then extend to the periphery. And take care, because this pattern is not specific for this type of pneumonia. This bat wing pattern, it can occur in many other diseases. Let's have a look on some of them. For example, see, it can occur in pneumocystis pneumonia, of course. Okay, it can also occur in people with pulmonary edema. You remember cardiogenic pulmonary edema? It will present also with a bat wing or butterfly appearance. It can occur in other type of pneumonia, inhalational lung injury, pulmonary hemorrhage, pulmonary alveolar proteinosis, and malignancy. But for your exam, you should remember that this pattern is suggestive of pneumocystis pneumonia or pulmonary edema, such as cardiogenic pulmonary edema. So let's come to the next point, which is also about the diagnosis. This point is commonly asked, and it's about how can we diagnose pneumocystis pneumonia. See, he will ask you, is beta D glucan and LDH are specific for PCP? No, it's not specific, because beta D glucan, it presents in the wall of many fungus or of many fungi, and it's not specific for PCP. So what's important, or what's diagnostic in PCP pneumonia, is histopathology. Histopathology is confirming, meaning that we should obtain a sample and do a test on this sample. So the sample here, we can bring it via induced sputum. This is very important, because he can give you an exam scenario and he asks you what's the preferred method to establish the diagnosis. In this case, it's induced sputum. Other types are bronchoalveolar lavage or even lung biopsy. And induced sputum, it's more sensitive than normal sputum or spontaneously obtained sputum from the patient. So if we do histopathology in this induced sputum sample, so what can we see? We can see disc-shaped cyst. This point is very important on methenamine silver stain. Okay, silver stain is important also, because if you find in the exams that this organism causing pneumonia requires silver staining to be visualized, so you should think of PCP pneumonia. Of course, there are many other types of stains, but this is high yield point. So let's have a look on how the pneumonia looks like. See how the organism, looks like. It's called disc shaped, or simply it's circular organisms, okay, obtained from induced sputum sample. So this is a bronchial wash stained with methenamine silver stain, highlighting the spores or pneumocystis spores. So he can ask you, how can this organism be stained? It's silver stain. How can the sample be obtained? It's induced sputum. This is the preferred method. So the other method which can be used is PCR. And PCR, it can be done on sputum and on other samples as well, such as blood or nasopharyngeal aspirate. So let's come to the prophylaxis. See, any patient with AIDS who have CD4 count less than 200, he should be started on low dose trimethoprim sulfa methoxazole. This is very important, and he can ask you in another way. Trimethoprim sulfa methoxazole in patients with HIV, it can be used for prophylaxis against two organisms. The two organisms are, the first is PCP and the other one is toxoplasmosis. Okay, so other prophylactic agents include dapsone or atuvacone if the patient is allergic to trimethoprim sulfa methoxazole. So let's come to the last point, which is about the treatment. Treatment is also trimethoprim sulfa methoxazole. And suppose if a patient is taking trimethoprim sulfa methoxazole and developed BCP, the treatment is still trimethoprim sulfa methoxazole. We don't need to change the antibiotic. So what about other treatment options? We have other antibiotics which can be used. See here, for example, in mild to moderate cases, the preferred agent is oral trimethoprim sulfa methoxazole, and alternative we can use dapsone plus oral trimethoprim, or oral primaquine plus clindamycin, or atuvacone. While in severe cases, we give it as intravenous injection, and we can use pentamidine or primaquine plus clindamycin. So you should remember that dapsone can be used for both prevention and treatment of BCP. So let's come to the next point, which is very important. When should we use steroids in a patient with BCP pneumonia? Steroids, the rule of steroids is that they are anti-inflammatory, because if you start treatment in these patients, there will be severe inflammation. So just in order to decrease this inflammation, we should give steroids. So the indication is moderate to severe cases. And you should know that moderate to severe cases is patients or are patients who have saturation less than 70 and AA gradient more than 35. If you find these numbers, he may ask you what should be added other than trimethoprim sulfa methoxazole, and the answer will be steroids. We have, so glucocorticoids or prednisolone should be added to antibiotics in patients with ... pneumocystis pneumonia. So it should be added to moderate to severe cases, meaning oxygen saturation less than 70 or AA gradient more than 35. And this is why we should add the glucocorticoids. So note, on initiation of antibiotics, inflammation first worsens during pathogen destruction. So glucocorticoids should be administered to reduce pulmonary inflammation, thus limiting the progression of respiratory insufficiency. So let's come to the last point, which is about don't be dragged. He may ask you, this question is very simple, but many times it's asked. So pneumonia in a patient with AIDS, it's according to the CD4 count. If the CD4 count is more than 200, we should think of strep pneumonia, because strep pneumonia is still the most common cause of bacterial pneumonia in normal people. And people with CD4 count more than 200, more or less, they are considered normal, while BCP is associated with CD4 count less than 200. So this is the first point. The second point is BCP increases the risk of secondary pneumothorax due to pollus formation, because also BCP is associated with formation of pneumocystis. Pneumocystis is air-filled sacs or spaces inside the lung tissue, and these spaces can rupture, giving rise to secondary pneumothorax. So we are done with BCP.